Very good afternoon, everybody. My topic for today is double trouble, a corneal ulcer with dacrocystitis. Certainly no financial relationship to declare. And the aim of the study was to explore corneal ulcer with dacrocystitis and the necessity of its management in the treatment of corneal ulcer and vice versa. Thank you. Thank you, Dr. Wiley. This is a retrospective and non-control case series from August 2017 to 2021, and as yet 13 cases from 13 eyes from 13 patients with corneal ulcer with dacrocystitis was included in this study. And clinical diagnosis of corneal ulcer, as everybody knows, and I added just OCT of our anterior segment, and lacrimal duct obstruction by irrigation examination of the lacrimal drainage system was performed immediately after the positive diagnosis with medical treatments. And lacrimal irrigation examination consisted of punctum dilatation, lacrimal sac massage, and syringing with commercial available moxifloxacin eye drop to determine the point of obstruction. And gender distribution was 4 male cases and 9 female cases. Total 13 cases I have taken, and organism isolated from 3 from male patients and from 7 female patients. Total 10 patients. The organism was positive sample was taken. Distribution of different isolates were staph in 5 cases, and Streptococcus species in 9 cases, and the rest of 2-1-2-1 year. And the antimicrobial susceptibility pattern of various bacteria isolated in my cases. Thus, I want to highlight one thing: ki ofloxacin is lesser sensitive than ciprofloxacin in my study against Staph aureus. And after diagnosis of corneal ulcer and dacrocystitis, patients were initially treated with topical broad spectrum antibiotics or antifungals in anticipation of bacterial or fungal infection, because I belong to rural areas and my main patients are from agricultural fields. And after diagnosis, drugs and eye drops ointment were given to the patients according to their clinical and pathogenic diagnosis. Corneal debridement and BCL were applied, and treatment of chronic dacrocystitis is DCR after corneal debridement and BCL. देखो ये आगे नहीं बढ़ रहा जी. Oh, good. Usually I do DCR by a small flap shaving technique which I have developed from 3000 cases. And the outcome is, after medical treatment, corneal debridement, BCL, DCR, and ulceration was progressed in first week. However, after 3 to 4 weeks of DCR, infection was controlled and corneal epithelium healed, and final outcome was satisfactory. And these are the few cases, and before healing and after healing. These are the few cases, example of few cases. And the corneal ulcer is one of the major cause of monoocular blindness, as everybody knows, and second only to that of cataract worldwide. And it is also one of the most common medical challenge in the developing countries, including India. And the known pathogens of corneal ulcer, as everybody knows, bacteria, fungus, virus, protozoa, or parasites. And in rural India's fungal corneal ulcer is still one of the major intractable diseases, composing an unusual high percentage of all type of corneal ulcer due to lack of antifungal eye drops and poor knowledge of antifungal medicine and injudicious use of steroid by quacks, especially Parimon, that's we call Paramon, especially in the clinics of the vast rural areas. Banerjee et al. All have reported the chronic conjunctivitis due to lacrimal system blockage can be relieved by DCR. And the ocular surface of healthy individual normally has a microbial flora, most commonly a small population of bacteria, typically coagulase negative staphylococci. And under the normal condition, these microbial flora may help to exclude harmful pathogens, maintain the immune response to the injury, and make the ocular surface a peaceful ecosystem. And however, when this balance is broken, the normal microbial flora would change, and because lacrimal duct obstruction might destroy the tear film dynamics, delay microbial clearance, change the normal microbial flora on the surface, and make cornea liable to be infected by gram-positive and gram-negative organisms. Although numerous studies on how to control and treat corneal ulcer have been reported previously, and the relationship between corneal ulcer and disorder of the neighboring tissue organ, such as chronic dactylocystitis, is still ignored in many cases, because the blindness may be caused by complication of corneal ulcer and lacrimal duct obstruction, while association between corneal ulcer and lacrimal duct obstruction is still ignored by scientific communities. And I have conducted this study to evaluate the effectiveness of treating infectious corneal ulcer with lacrimal duct obstruction. And inconsistent with the previous studies, the most common obstruction point in our study was lower canalicular occlusion, and the high risk of lower canalicular occlusion could be secondary to ocular inflammation due to corneal ulcer, and toxic effect of topical medicines might increase predisposition to lower canalicular obstruction. And to best of my knowledge, on one hand, lacrimal duct obstruction may delay tear film clearance, change the normal microbial flora, and make cornea liable to the infection. On the other hand, corneal ulcer may promote the obstruction of the lacrimal duct, especially lower canalicular obstruction. Thus, it is important to make an early diagnosis of lacrimal duct obstruction for corneal infection control. And this is my first cases. We presented with left eye ache, redness, congestion, and photophobia, lacrimation. That's why my dedication to doing the study to this patient. And the take-home message is evaluate lacrimal duct obstruction in conjunction with the treating corneal ulcer, because in many cases patients are with photophobia, foreign body sensation, and very uncomfortable, and most of the time we do not go for examining lacrimal duct and lacrimal area. These are the references. Thank you.
Thank you, Dr. Ranjan. That was a beautiful